Thank you so much. So it is with great honor and pleasure that I get to introduce our first speaker, Dr. Susan Buchanan. Susan Buchanan, Dr. Buchanan, come on up, is coming to us all the way from the great state of Chicago. She's with the University of Illinois at State. What did I say? Oh, I mean, same thing, right? State of Illinois, from the University of Illinois at Chicago in the School of Public Health. Dr. Buchanan is also the director of the Region 5 Pediatric Environmental Health Specialty Unit. She has a particular interest in this topic. We also have a PACU here. PACU is the acronym, and Dr. Sheila Satyanarayan is a representative and a member of that group. If you don't know who the PACUs are, we should talk about that later. So, Dr. Buchanan, thank you.
Thank you. Okay. So this is probably the longest talk you're going to hear today. Hope I'm going to do it in 15 minutes. I want to go quickly because there's a lot I want to tell you about if you're not familiar with reproductive environmental health. I want to give you the big picture right now. All right, so I'm getting some federal funding from the PACU, so this is my disclosure slide. So next slide, we don't need to linger on that one. All right, so let's look at what is a definition of reproductive environmental health. What the heck does that mean? So it can be environmental exposures during preconception or the prenatal period that affect mom's health during pregnancy, fetal health and development while in utero, organ development and function in the offspring after they're born, male reproductive capacity. I've been tasked today with bringing up the male reproductive issues because we don't want to forget about them today. So you'll be hearing about that as the day goes on, different exposures that affect male reproductive capacity. Reproductive environmental health can also be environmental exposures during the entire life cycle that affect reproductive capacity. So we're not really just talking about pregnancy. We're talking about adult men that are exposed in the workplace and then have decreased sperm counts and then have difficulty conceiving. What is reproductive environmental health? Not this. This is an article that came out in the Huffington Post, or maybe it was the Daily Beast a month ago. Medicine bedevils pregnant women with too many warnings about risk. And it really takes the medical community and us, environmental health folks, to task for scaring women too much. Don't do this, avoid this, avoid this. This is an issue that is a real one and one that we want to avoid. So we have to be really careful with our messaging and not scare pregnant women so much that, for example, they stop eating fish altogether if you scare them about mercury in fish. Nevertheless, there are approximately 84,000 chemicals listed by the EPA. 700 new chemicals are released annually. 3,000 chemicals are high volume or exceed 1 million pounds of use per year. The vast majority have not been researched nor subject to standard studies. So there's a lot out there. And yes, we're all exposed. This table is from a study from UCSF, Tracy Woodruff et al., and she took a large survey that's done by the federal government every year and looked at the blood samples in pregnant women for chemicals. And this is just one chart from her published study. And each bar is a different pregnant woman, and each column is her blood test. And you see that the chemicals were found in every single woman. The only one that wasn't found in every woman is cotinine, which is a cigarette smoke marker. So in every woman there were phthalates, which are plasticizers, polyaromatic hydrocarbons, which are products of combustion, flame retardants, pesticides, and metals like arsenic, lead, or mercury. Next slide. And then these are the trends in health effects. Okay, so we know there's lots of chemicals. We know they're all in our bloodstreams. What does that mean about health effects? This is from another paper by Tracy Woodruff from UCSF, showing trends in epidemiologic trends in health outcomes, showing that testicular cancer is going up, autism, ADHD, the male birth defects of cryptorchidism, which is when the testicles do not descend into the scrotum, congenital hypothyroidism, infertility, including in women less than 25 years old, is increasing, prematurity, preeclampsia, gestational diabetes, age of puberty, sperm count, look there at the bottom, 1% decline per year since 1931. So there's a very dramatic change in sperm count since World War II, and serum testosterone. So what is the scientific community doing? This is a really interesting graph. You can just look at the white line and show the dramatic change in the number of scientific articles that have been published on reproductive environmental health from 1979 to present. So this is back in 1979, and then this up here is 2009, and then the research assistant that did this looked at only half of this year. So ignore this decline and just notice this increase in the number of scientific articles. So there's a lot of work going on. It's just mushrooming in the last 10 years. And these are the exposures that these articles are covering. And I'm sorry, again, you can't see them. I'll just go through them really quickly. Air pollution, dioxins, flame retardants, these products of combustion, mercury, the Teflon chemicals, PCBs, phthalates, lead, pesticides, BPA, a couple of others. So that gives you an idea of what exposures are being studied. And here's the health outcomes that this research is looking at. Reproductive capacity, like age of menarche, so when girls get their first period, menstrual irregularities, onset of puberty, anovulation, semen quality, and then this organ function in the offspring. Remember, we talked about reproductive environmental health is also the health outcomes that come from exposures during pregnancy. But lung issues after the child is born, thyroid, immune system, cancers, response to vaccines. Then thyroid issues and blood pressure issues in moms during pregnancy, birth defects, preterm birth, low birth weight, obesity, and a very important one, neurodevelopment, for example, IQ and behavioral issues, and then infant mortality. So those are an example of the health outcomes that are being examined by this ballooning number of scientific studies in this area. But what are the OBs, what are the obstetricians learning? This is a survey of the obstetric literature over, I think this research assistant was looking at 14 months. And in the Green Journal, which is the #1 journal for OBGYNs, there were 0 articles. In Contemporary OBGYN, which is another major journal, 0 articles. And the American Journal of Obs and Gyn, there were 4 articles, 2 of which were ours, one from UCSF and one that Sheila Satyanarayana senior authored. And here are toxicants that are known to be important to fetal origins of disease, and the ones that we will probably cover today. Air pollution, including particulate matter, diesel, polyaromatic hydrocarbons, which are products of combustion, heavy metals like mercury and lead, and then other chemicals like pesticides and plasticizers and flame retardants. Now, the next 5 slides, I just have 5 really quick slides of studies, and as I was falling asleep last night, I thought, I should just really make these charts smaller and the findings bigger because you don't really care about these tables, but I just want to show you 5 really interesting studies that I came across in this literature in the last few years. So this first one is looking at these PAHs, which is what comes off from burning of fossil fuels in pregnant women. And this researcher, Frederica Pereira, had African American and Dominican mothers during pregnancy wear air monitors. They wore these backpacks, and it measured all the pollution they were exposed to. And then it looked at their levels in their blood of these pollutants, and then checked child behavior, did testing on the child's behavior at age 4.8 and 7 years. And the 2 red boxes just show a statistical significant change in a decrease in the child's behavior, abnormalities in the child's behavior as the mother's doses to exposure goes up. Next one. And then this one is showing levels of benzene in the mother's air, just the air around the neighborhood. These were just big monitors around the neighborhoods, showing levels of benzene and neural tube defects, and found a statistical significance with increase of occurrence of spina bifida and higher neighborhood benzene levels. Next slide. This is one on pesticides, and this found a drop of 7 points in IQ between babies who were, or mothers who had higher exposure to pesticides in utero and IQ in the children at age 7. And the red box just shows this trend in loss of IQ with mom's exposure to pesticides. And this might be the last one. So flame retardants, they're in the news now, and this box is showing the mother's exposure to flame retardants and her thyroid level. Now, thyroid hormone is extremely important for development of the fetus, for neurodevelopment and other organ development. So there's a great worry about flame retardants interfering with thyroid in the moms. Okay. Oh, this one's the last one. So this one's bisphenol A. This was a big study on children's behavior and their exposure to bisphenol A. So they took mother's urine during pregnancy for BPA, the plasticizer, and then did a behavior assessment on the kids when they were 3 years old. Go ahead. And this slide just shows for the girls that as mothers' urinary plasticizer levels go up, their abnormalities on emotional control, inhibition, anxiety, and depression increased. 3 years old. Okay. All right, so that's just a quick overview of what's going on in the science, just an example, not really an overview, but just an example of what scientists are looking at now. And then I was also asked to kind of go over what's new just in the past few years. So I want to emphasize 3 things, that there are new lead guidelines, and I bring them up because when I speak to OBGYNs and residents, they don't know about this and they're not doing it, even though the CDC published these guidelines in 2010. And then we are increasing our attempts to outreach to prenatal health care providers. We're starting to think about what we might tell OBs and any prenatal providers. When I say obstetricians, I mean nurse midwives, family docs doing deliveries. I'm a family doc and did deliveries for 10 years, so I'm in that group. And then we also have a work group that's focusing on education, clinical practice, and policy. So here's these lead guidelines. I just want everybody to know they're out there. 2010, CDC spent many years looking at this. What should we tell doctors to do about pregnant women's exposure to lead and whether to screen them? And when the CDC put something out, it's a big deal because it meant they sat around a table for probably a really long time and argued about it, and they finally came to agreement on what to publish. All right, and this is what their document looks like. And then this is one of their figures. They suggest different, unfortunately, I feel like they're not very strong in telling doctors exactly what to do, but I think that's really typical. People are so afraid to just come out and say, do this. But anyway, I'm sure they looked at a lot of data and were unable to come up with exactly what they want folks to do, but they suggested Minnesota does this, New York City does this, and this is what New York City does. These are the screening questions that should be asked to every pregnant woman, and if there is a yes on any answer, she should have a blood lead level. Okay, so the questions are, were you born outside the United States? So being born outside the US, no matter where you're from, confers a risk for higher lead. During the past 12 months, did you use any imported health remedies, spices, foods, ceramics, or cosmetics? As you may know, a lot of those can contain lead. At any time during pregnancy, did you eat non-food items? So pica during pregnancy causes women to eat crunchy things that are sometimes ceramics with lead in them. In the last 12 months, has there been any renovation or repair work in your home or apartment building? So we're not even asking how old the house is. If you had any repair, do a lead level. Have you ever had a job or hobby that involved possible lead exposure? Glass, ceramics, jewelry. There are occupations like battery manufacturing facilities still, many in the U.S. that cause that result in lead exposure. So lead guidelines. All right, the next one. So what do OBs know? We talked about what is their literature showing. They don't have many articles in their literature. Now this was a really interesting survey that was done at UCSF of OBs around the country, and these were all the OBs that participated. Next slide, and it showed, it was a survey on what do they know and what do they do about environmental health. 78% of OBs feel they can reduce patient exposure, and what you can't see here in black is yet less than 25% report that they take an environmental health history. Next slide. They do, so what 100% of them, what do they ask about? They do ask about diet, alcohol, smoking. Less than 20% ask about chemicals in the home, personal care products, use of plastics. So the UCSF group worked very closely with the president of ACOG and the president of the American Society for Reproductive Medicine, and they initiated an initiative in their organizations to publish this committee opinion. So this is a big deal. So ACOG is the professional organization for OBs, and the Society of Reproductive Medicine is the society for infertility docs. And they put out a committee opinion on exposure to toxic environmental agents. Next slide. Now, once again, they are not telling OBs what to do. Nobody's yet giving guidelines about what should happen in the exam room. But this committee opinion says that reducing exposure is a critical area of intervention. So they're recognizing this as a problem, which once again is a big deal. Okay? The big OB professional group says, okay, we're recognizing this is a big deal. Second bullet, the evidence is sufficiently robust. This is also a big deal because doctors don't want to change their practices unless there are a zillion studies showing that there's a benefit. And even then, it's really hard for them to change their habits. But so these two organizations said, okay, we've looked at the evidence and we've got enough. The third bullet says that these two organizations, ACOG and ASRM, should join leading scientists and other practitioners in calling for timely action to identify and reduce exposures. So just mainly joining in the effort that more needs to be done. So what are the implications for clinical practice? This is from a high-risk OB doctor friend of mine in Chicago who put this together of what are the implications for clinical practice of this opinion, of this movement. What is the opportunity for prenatal health providers? They can detect environmental threats, educate patients, mitigate the impact of exposures, and then advocate. They can advocate for their patients by screening them. They can advocate for their communities by working with groups of patients and community leaders, and they can advocate at the policy level. Next slide. And this one I put together as just my thoughts on what should clinicians be considering doing, because that's what the clinicians want to know. Okay, what do you want me to do that's different in the exam room? And those of us who are concerned with this issue, we recognize that patients are going to listen to their healthcare provider, often in contrast to anybody else, including family members or whatever. So let's try to do something about what's happening in the exam room. So here's some of the things that I have put together that we're starting to talk about. Maybe they should consider asking either a single fish consumption question, a couple of lead exposure questions. We're not going to give them a whole history form, although we have one that I can show you because they're not going to do a whole environmental history. So let's maybe pick some low-hanging fruit. They can educate themselves. There are now CME modules that are going to go live from UIC in a few months on healthy fish and air pollution effects in pregnancy. They can utilize the PACES, which Margot mentioned. These are federally funded regional sites for expertise in children's environmental health. And because we do children's environmental health, we also know a bit about the reproductive environmental health, and we're educating ourselves more and more. And then we have this work group that was just formed in the last few years of scientists and government people and people from NGOs and universities. Next slide. This is an example of the environmental exposure history form that we put together at UIC. It has different sections. Like have you or anyone in your house ever been treated for lead? Is there a mercury thermometer in your home? So there's a lead section, a mercury section, and on the other side are steps that pregnant women can take to reduce risk. Next slide. That's a picture of the whole history form. I told you OBs, nurse midwives, family docs doing prenatal care. I used to have 10 minutes per visit. I would see 20 women in a half a day. And so there's no way that I was going to do this on every woman. But we put it together because, well, I don't know, that's what educators like to do. Let's put together a history form and hope doctors do it. But I try to be realistic. And one of the things that our working group is looking at is how to get environmental history questions put into the new electronic health records. Because when a pregnant woman comes in, she takes this history. Do you do this? How much alcohol? Do you change the kitty litter? Blah, blah, blah. Do you exposure to lead? How many fish do you eat? Just get those inserted in as a first step of trying to reduce exposures. Okay, so I really look forward to the rest of the day, and I hope this has kind of just gotten your brain working, thinking about exposures and reproductive health.
Can I use this? Thank you so much, Dr. Dr. Buchanan. Hey, I think it's time for a prize. So before, I'm so happy with myself that I remembered. I just wanted to get a show of hands for who here is from the healthcare provider field. Are you a pediatrician by chance? Any pediatricians work with kids, nurses in the healthcare provider field? Excellent. Excellent. So many nurses. How do I choose? Okay, you don't count, Tony, because I know you already know this stuff. One of my speakers, I saw your hand come up first, so I'm just getting, and you're closest to me, so it's so easy. And this is the Green Book, and if you don't know what it is, it's put together by the American Academy of Pediatrics. It's a desk reference book for pediatricians, and I would like to give you one. And I do have one more, so you just stay put in your seats and just get ready to raise your hand very, very quickly. Thank you. As our first panel is making its way to the stage, please, Elise and her first panel. I just wanted to say, that talk by Dr. Buchanan, for me, of course, all of us are here for our professional interests in this very important field. And if that didn't convince you, Dr. Buchanan's talk didn't convince you, I hope you're convinced now, throughout the rest of the day. But also, I know we come also to this field from very personal places as well. And I wanted to turn your attention to, in your program packet, you should have a handout that's separate from the program titled Notes for Effective Action. And that notes document is really meant to help us guide our conversations today. So when you're listening to this next panel, be thinking about what resonates with you, whether it's on a personal level or a professional level. So what? Why are these issues important to us? It might be important because you work in this field. It might be important because you have grandchildren and you want to ensure their reproductive health in the future. And then I want you to take that last row there that says, now what? So what are those ideas that you can bring into this work, into your field, your organization, your affiliation, your group that you're working with to move forward in these issues? And this is really meant for you to be a note-taking guide, and later on we're going to get you to do some talking around your table and some actual work with it, so that's your fair warning. So it's with my great honor and pleasure again to introduce Elise Miller. Elise, you want to stand? Elise Miller is the National Director of the organization called Collaborative on Health and the Environment. And I'm just so thrilled to have Elise here to be moderating our first session. So I'm going to hand it over to you. And you're mic'd, right?
Thank you. I think I am. Can everyone hear me? Great. Well, what a delight to see so many people out here this morning. And I am just feel grateful beyond measure that these incredible colleagues have been organizing all this, and I haven't had to do anything but to show up. So it's just, it's really remarkable to look at what Che Washington has been doing, and it's really because of these core folks like Margot and Amy Boulanger and Gail Ginsler and Julie Berg and, Song. Singer, I'm sorry. She changed her last name. I apologize. And so many others, Steve Gilbert, other people have been keeping this going since we first started Che Washington. And I've had very little to do with it, and it's really because of their energy and strategic thinking and so forth that has kept this work in this region going, and I'm just really grateful to all of them. So we actually have an incredible lineup of national sort of superstars in the environmental health field. I'm just it's amazing to have them all here, and little did you know. And we're going to just do a little overview of what is reproductive environmental health, and we're going to actually start with Ted Shetler, who's going to give about a 10-minute spiel, and then we're going to turn this into something of a conversation that I'm going to try to facilitate. And I do apologize for those of you who are on the corners, not able to see everybody very well or the screen, but I'll try to, anyway, come around and we'll try to make this more of a conversation. So I'm going to introduce all of our speakers first before we turn it over to Dr. Ted Shetler, and is it okay if I take a seat? So Ted Shetler, Dr. Ted Shetler, is someone I've known now, 15 plus years. And he has been working for, at least a couple decades on helping connect all these different factors that influence our health, including the built environment, nutritional environment, the chemical environment, our socioeconomic status, our psychosocial experiences, and all of these factors, and making us think through in this much more ecological framework. And through that process has been focused on spearheading efforts on the precautionary principle and also now looking very much at what are interventions that we do, given what we know, what are interventions that can help reduce disease and disability. And I introduced Ted a few years ago, and I think it was the 2009 forum. Ted came to that as well, and organized by the same wonderful colleagues. And I said he was the go-to guy in environmental health, which is true on everything from learning disabilities to reproductive health to cancer and so forth. And this is still very much the case, and we actually kid him quite a bit because when all of us were first trying to understand, what the TED Talks were all about, and we thought, gosh, Ted is giving all those talks, right? Because he's so knowledgeable on all these different subjects. And then it was like, oh, the TED Talks. So anyway, thank you so much for being here, Ted. And again, I'm going to introduce everyone first. So who do I have next on my list? Well, I have Dr. Susan Buchanan, but I won't reintroduce her except to say that I don't think we've ever actually met. And so I'm just delighted to have this opportunity and spend some time with you. So thank you.
Thank you.
And then Karen Gunther Russ. This is Karen, and Karen is the director of the Collaborative on Health and the Environment's Fertility and Reproductive Health Working Group. And so we've been working together now for, about 3 years? And that has just been a great pleasure. And so she basically works with researchers and health professionals and advocates and clinicians and so forth to disseminate this information on the emerging science on reproductive environmental health, and then to help facilitate various initiatives particularly among some of the experts in the field to frame the science and how it can be applied in clinical and policy settings. And so just so grateful to have your expertise and energy in this work. And then next to me, we have Sheila, and I will never, even though I lived in India for 2 years, you would think I would just have this come right off my tongue, but Ranayana, yes, great. Sheila, we love that first name, so I apologize. And so Sheila also she's based here, fortunately for us, and she's assistant professor of pediatrics and an adjunct assistant professor with the Department of Environmental and Occupational Health Sciences at the University of Washington. And she's also a pediatric environmental health specialist and is currently serving as the center director and the clinical director for the Infant Development and Environment Studies, which is a multi-center cohort study, which you may talk more about, of phthalate exposures in pregnancy and the health outcomes in children. So we've been very grateful to have her leadership and expertise in this region on these issues and nationally as well. And last but not least, Kim Hurley. Dr. Kim Hurley is an adjunct associate professor in the Maternal and Child Health Program and associate director of the Center for Environmental Research in Children's Health at UC Berkeley. And she's also a reproductive and perinatal epidemiologist, and I could talk much more about her work, and again we have the bios, but I haven't had a chance actually to really spend time with Kim either. I know her colleague Brenda Eskenazi has been doing a lot of this research in the Salinas Valley in California on pesticides and farm workers, and it's really it's just great to have you here too. So I will stop there and turn it over to Ted for 10 minutes, and then we'll move into a conversation.
Well, good morning. Thank you all for coming, and thanks very much for inviting me. It's a pleasure to be back in Seattle. To go to the first slide, I have a really quick task to take a few minutes and say a few general things about what was sort of billed as Reproductive Health 101. And I'm fortunate that Susan really sort of laid it all out for us. So I'm just going to make a couple of other points in addition to what Susan has said. I do want to emphasize the importance of the preconception environment. And as Elise sort of mentioned, I think we need to look at all of these environments when we're thinking about the importance of the preconception environment. The chemical environment, to be sure, but also nutrition, the social environment, the built environment in which parents-to-be are living has a large influence on their health. And we obviously have to be concerned about general parental health before pregnancy, many of these factors can influence egg and sperm quality, as Susan mentioned. And collectively, these really influence successful fertilization, implantation, the uterine environment, and the ultimate success of pregnancy. What we see here is sort of a graphic displaying some of the features of the environment that collectively influence fetal growth and development. Toxic chemical exposures, the nutritional environment, the genetic background against which this all happens, the social environment, infectious agents, and others influence pregnancy outcomes, and Susan laid out some of the health effects that we are concerned about. And I just want to add to that we're now learning from a lot of very interesting research that's addressing the whole issue of the developmental basis of adult disease, that actually during this time period, the risk for health later in life can be strongly influenced, including cardiovascular disease, stroke, hypertension, and cancer risks that may show up many, many decades later can be influenced by what goes on in the fetal environment. So this really is a life course approach. Some of the things to keep in mind about this particular time are that there are unique biological events that are occurring during fetal development, which leads to this concept of unique windows of vulnerability. And this is going on in virtually all biologic systems in the developing fetus. The brain, the immune system, the endocrine system, and so on, that are exposed periodically to various things that come in from the environment that can influence the trajectory of development. And the take-home message here is that the timing of exposures matters. We know, for example, from studies and tragic experiences with pharmaceutical agents where an exposure may occur at a window of vulnerability during fetal development that can result in a severe birth defect that might not or would not have happened had that same exposure happened at a different time in pregnancy. So the timing of exposures matters, along with the amount of the exposure and the duration. And there are many mechanisms by which fetal development can be altered. This is not meant to be an exhaustive list, but I just want to point out a couple of things here. The whole idea of endocrine disrupting chemicals, where signaling mechanisms can be altered by environmental exposures that then have a long-term effect on the development and function of organs later. And the other concept is that of epigenetic changes. This is an idea that describes how environmental exposures, whether it's chemical exposures or nutritional, can alter the expression of genes without actually causing gene mutations. And those alterations in gene expression can actually be lifelong as well. So that there are concerns about how the genetic manifestation plays out during life, after birth, and so on, and gives us an opportunity to really understand how gene-environment interactions work. That it's not just genetic background or environment, but that they actually interact, and the environment can affect gene expression. And for those of you who are interested in more detail about windows of vulnerability, depending on what's going on at various times during pregnancy, I just refer you to a nice a website called the Endocrine Disruptor Exchange, which you can easily pull up by just searching for that name. And it's a very user-friendly website that shows you what's going on at various times in pregnancy in terms of brain development, immune system development, reproductive system development, and so on. Susan has already told us about some of the health effects that can result from abnormal fetal development, including fetal death, preterm birth, birth defects. The functional abnormalities are really important. You don't see these necessarily at birth, but when you do testing later on, you find out that fetal exposures, for example, the pesticides that were mentioned, that's some of Kim's work, showing the effect on neurodevelopment of children that can be actually identified a number of years later. And then there are actually some data supporting the idea that childhood cancers actually can originate in the womb because of exposures there. And we don't want to leave out a dad. paternal exposures to carcinogens in some studies, but not all, actually do increase the risk of childhood cancer in offspring. Next slide. Environmental chemicals can be encountered in the home, at work, in the community, in the diet. And if we're thinking about the preconception period, as Susan mentioned, we don't want to scare people away from eating any fish, but we don't want people to be eating fish that's loaded up with mercury, because prior to pregnancy is an opportunity to actually address that. If somebody has a lot of fish consumption in their diet and it happens to be high in mercury, if that's identified before pregnancy, there's actually an opportunity to alter the diet, and over a period of several months, mercury levels will fall. So there are some opportunities in the preconception window to actually try to improve the environment that will be present during the time of pregnancy. Then during pregnancy, there are a number of chemicals to be concerned about that can be reproductive or developmental toxicants. I've just put here the California Prop 65 list, which you can find online quite easily. And it lists those chemicals that have been identified by the state of California as known to be reproductive or developmental toxicants. And let's not forget pharmaceuticals, and that includes over-the-counter medications, that they also can disrupt normal fetal development. I just want to emphasize the importance of the nutritional environment as well. I mean, there are obviously things like paying attention to fruit and vegetable consumption, healthy fats, and low glycemic carbohydrates, as opposed to a lot of refined grains and carbs that lead to insulin resistance and can really cause problems. And there are actually some studies showing that high glycemic carbohydrates diets can actually increase the risk of having a child early, preterm birth. And with respect to vitamins and minerals, we know that there's a lot of emphasis on folate in prenatal vitamins because of the demonstrated effects on lowering the risk of having a child with neural tube defects. But I also want to point out that there are strong recommendations for iodine in prenatal vitamins that are simply not being followed by many manufacturers of prenatal vitamins. Over half in one survey did not have any iodine in them. Why is this important? Because about 30% of women of reproductive age in this country have insufficient levels of iodine when it's measured in their urine. And we'll hear later today, I'm sure, about some of the chemicals that can disrupt thyroid function. And it's not just one chemical, but a whole series of them that can have effect on thyroid function. Iodine is essential for having normal, healthy levels of thyroid hormone, which is essential for normal fetal development. So we really should be emphasizing getting iodine in prenatal vitamins. Similarly, vitamin D. ACOG has a recommendation that all women who are at risk for insufficient vitamin D levels should be supplemented during pregnancy, and it's not being done. And who's at risk? Well, depending on who you choose as your expert, between 30 and almost 60% of people in the United States have insufficient vitamin D levels. So it's a big public health issue that really needs to be addressed beginning in pregnancy, and it's not being done adequately. I've mentioned the importance of the epigenetic markers and how these can have long-term effects on organ function later. And there is a publication that's been produced by ACOG called Nutrition During Pregnancy that's available on their website for people who are interested in more. And let's not forget the social stressors. We'll hear more about that later today. But these can both be acute because some of acute life event happens that causes stress before or during pregnancy, as well as chronic, lingering, relentless stressors of certain kinds of lives that lead to chronic stress, which can actually cause biologic changes that are measurable and influence pregnancy outcomes. And when you put them together with inadequate nutrition and chemical exposures, you really begin to see how we're creating a system that is not likely or is less likely to result in a really healthy outcome. On the other hand, if we think about the opposite, the other side of that, what are the things we can do to ensure a healthier outcome? We begin to see where some of those interventions can be. And then this is my last slide, that one way to think about this, and Susan already mentioned a questionnaire for clinicians to use, but I use this acronym CH2OPS to remind me of the community, home and hobbies, what's going on in a person's home, what are the occupational exposures, what are the personal exposures, and then the socioeconomic conditions. If we begin to think about those collectively, I think we begin to see where there are some opportunities to not only do research, but also intervene to improve the likelihood of a healthy pregnancy outcome. So that's all I have, Elise, and I'll come over here. Sure.
Thank you, Ted. So we're going to I'm going to sort of prompt some questions, and what I hope we'll do is just elaborate on those and try to have more of a back and forth, so it's not just you all looking to me for the next prompt. But I first want to kind of open it up to any of you on the panel who'd just like to respond to or add to what Ted just presented briefly.
The epigenetic effects are a burgeoning area of study. And so I hope we'll have time to touch on that later, because I think that's really going to be important in delivery of medical care in the future.
Why don't you go ahead and elaborate a little bit more now on the epigenetics? And Karen also has this strong background in looking at these issues around fertility, so you might want to bring that into it. So why don't we jump in there?
So I was asked today to talk. Thank you. I was asked to address some of the issues about infertility and environmental exposures under the framework of, we are talking today about healthy pregnancies, healthy babies, but certainly can't even get to that point if a couple is experiencing difficulty conceiving and carrying the baby to term. So as Susan laid out so well, there's a variety of environmental toxicants that really contribute to infertility, both in males and females. And so I'm just going to make a very brief mention on the male end. There's a lot of data from that Dr. Shetler so nicely summarized in a paper for CHE in 2011. It's available on the CHE national website. And the chemicals and agents with the strongest associations for male infertility are pesticides, phthalates, solvents, PCBs, metals, and including other agents like components of air pollution. And there's a growing evidence base for electromagnetic frequency radio waves from cell phones and laptops. And then on the female end, the agents with the most implications to contribute to endometriosis, problems with menstruation, and problems with ovulation include heavy metals, pesticides, solvents, and PCBs. And that leads me to the discussion about the epigenetic expression. As Ted said, we're all born with our certain genome, and we may have a predisposed risk for a certain disease. And I'm explaining this to sort of parent groups. Often we'll talk about, people are very well aware of the BRCA gene. If someone has a BRCA gene inherited, they're that much more likely to have breast cancer down the line. But certainly it takes all kinds of different factors contributing as well, nutritional and environmental, to make that gene express. And now epigenetics is showing that various chemicals in our environment have the ability to turn that gene on or turn that gene off. So that is where my comment came from, that that is going to be a really important aspect when we've talked about the human genome being such a crucial part of predicting our disease later in life. And now we would like to, at CHE, would like to draw more attention to what's also been called the exposome, the variety of different components that we're all exposed to over our lifetime. So I think I'll... Excellent. So I think I'll leave it at that. If anyone else would like to comment on epigenetics, or...
I just wanted to make one follow-up comment about the epigenetic work that's being done, and this is really an exciting new area of research. But one of the things that's getting a lot of attention is that some epigenetic changes can actually be inherited. So it's not an actual change to the DNA, but it's these changes on top of the DNA that may actually be inherited to the next generation. And what we're starting to see now in some animal literature and even a few human studies is we're seeing that exposure in utero to a woman we know it can have impact on her daughter, but now there are studies that are showing that the granddaughter may also be affected by that exposure that had now happened 2 generations above. And so that's a really important consideration to be thinking about when we're thinking about prenatal exposures. And
I'll just add to that I guess yesterday on a call with Dr. Philippe Grandjean in his new book, Only One Chance, and he's done a lot of research, particularly around mercury issues internationally. And one of the points he brought up, which I thought was interesting, one of the studies was about looking at these children who had been exposed to mercury, and many of them didn't manifest any IQ deficit or any concern. But when they looked at 4 gene variants, and when they correlated those to the mercury exposure, those were the kids with those gene variants, who then showed quite a significant drop in IQ. So this is really, it definitely complicates things, but it's an exciting new field. So.
Just to give a real-life example of that transgenerational inheritance that Kim spoke about is diethylstilbestrol. So many of you who are practitioners might know DES, and it was used to prevent miscarriages. And so the women were taking it to prevent miscarriages, and then their offspring had a very high risk of vaginal adenocarcinoma. Both the male and female offspring had major issues, but now in current studies, that generation is having kids of their own, and they are also having reproductive malformations. And so that is a very classic example of that transgenerational inheritance, and it really must be through an epigenetic mechanism, although that mechanism has not been identified specifically at this point.
Other comments on that? Whoops. Well, why don't we, Susan, you were beginning to talk more about the role of men and how we can help with intervention or prevention in terms of their experience. And maybe you could touch on some of the studies and work you've been doing. Aderi.
Well, a lot of, I haven't been doing research myself. I've been reading the literature, and I read your write-up for Che, and I took some of that information on a talk I put together last spring because I started to realize that it's a fascinating issue, the role of men in pregnancy outcomes. And excuse me, unfortunately, a lot of things we learn about in occupational and environmental health, we learn because of disasters and plants exploding and workers being overexposed. And one of the classic cases was a group of workers at a pesticide plant in California who noticed in the 70s, I think it was, that they noticed among themselves that they were having trouble fathering children. And they went to a physician who performed sperm counts, semen analysis, and found that some of them had absolutely no sperm and some of them had low sperm. And it took several years and was eventually discovered that it was exposure to the pesticide in the plant. They were using inadequate protection. And after that was published, there were other pesticide plants showing that male workers had effects on their semen analysis, on not just the sperm counts, but how well the sperm swim, the shape of the sperm, all these important aspects that contribute to whether a sperm is successful in fertilizing an egg. So the history is fascinating, and a lot of the research at this point is on workers, because it's often the workers that are getting the highest dose of the exposures, and that's how we learn about what happens in the environment of a chemical, is first look at the workers who are making the chemical or working with the chemical. So a lot of the literature is on male workers in plants, and I think both of us kind of mentioned some of the chemicals that are important, including, Karen, you did, solvents and metals and pesticides, now plastics. And the actual mechanisms are not well understood. What is it about an exposure in a male that then passes on a health effect to the offspring of that male? We don't exactly know, and that's why we talk about this epigenetic phenomena, these chemicals, natural chemicals in the body, these proteins that are attaching to the DNA and basically doing the wrong things. And so the DNA gets passed down, and then the DNA is told to make in the cell the wrong type of protein, or don't make thyroid hormone, or make too much thyroid, or don't make estrogen. And so these are probably the effects that are happening when the male is exposed and then passes something on to its offspring.
would add something. Can I add something? I just wanted to speak a little bit more to possible mechanisms, and it seems a little counterintuitive. How could the father's exposure impact miscarriage rates, for example, in his partner? It doesn't seem to make sense. But one of the things that we see is that certain occupational exposures or environmental exposures may cause chromosomal damage in the sperm. And sperm that have chromosomal damage, when they join with an egg, that egg is going to be incomplete and is going to be less likely to be viable. And so you can see that some damage that happened upstream in the father's sperm may literally upstream, may actually make his partner more likely to miscarry that fetus, or if the fetus does actually survive till birth, may have an increased likelihood of a chromosomal birth defect. So I think often we think only of the mom when we're thinking about fetal development, but there are ways in which factors that are ways that the sperm is being exposed can affect that whole course of pregnancy.
Maybe you want to elaborate on your work with chamacos in the Salinas Valley along those lines? I know there's a lot to say, but...
I'm happy to talk about the chamaco study. We haven't done a lot of work with the dads.
Okay.
Most of the work we've done is with the
Well, go
moms,
ahead
but
and-
if we're ready to talk
sure.
about it. I work for most of the work that I do for much of my career now, about 12 years, I've been working with a cohort study in an agricultural region of California. It's the Chamaco study. Chamacos means children in Mexican Spanish, and we have about 600 families. Many of them are farm workers. They're all low-income Latino families. Not all of them are farm workers, but they all live in this low-income agricultural community. We enrolled 600 mothers during pregnancy, and our children are turning 14 in February. We've been following these kids for 14 years now. We took multiple biological specimens over these years. We took blood samples and urine samples during pregnancy. And then over the last 14 years, we've been doing physical exams of the children, neurodevelopmental tests of the children. We have their medical records. We see the children about once a year. The time has varied, but we do about a 3-hour neurodevelopmental test battery on them each time we see them, including IQ tests, motor skills, memory skills, executive functioning. And what we found when we started, we looked at levels of pesticide metabolites. Specifically, we're looking at organophosphate pesticides, which are one of the most toxic insecticides and also one of the most commonly used insecticides. The levels, the moms that had higher levels of these organophosphate pesticides in their urine during pregnancy, when their babies were born, as neonates, they had more abnormal reflexes. But for people who work with neonates, that doesn't really mean anything. So as the kids got older, we found that the moms with the higher levels, their kids at age 1 and age 2 also had poorer mental development. But again, how do you measure mental development in a 1 and a 2-year-old? Well, by 3.5 and 5, they were having decrements in their language learning. And the paper that Susan presented earlier today, by age 7, now the children are school age, we're able to do a full IQ test on these kids. And we see that the kids whose moms had higher organophosphate pesticides in their bodies during pregnancy, their children were a full 7 IQ points lower at age 7 than the kids with low exposure prenatally. Now, 7 IQ points, to put that in a frame of reference for you, that's about a 6-month developmental delay. So we're saying a 7-year-old who's performing at about a 6.5-year-old level. Another way to put that in perspective is that that's about the same IQ drop that we see with early childhood lead exposure. So these pesticides are acting on what we're seeing is an association that's similar to what we see with lead. One more thing I do want to mention, we've been talking about critical timing of exposure. In our population, we also measured pesticide exposure in the kids as they were getting older. We see this really strong association with the mom's exposure during pregnancy and her child's later IQ, and also I should mention attention problems, pervasive developmental disorders. We don't see any association with the child's levels. So we looked also at the levels of pesticides in the kids, and it's not, in our study, it's not associated with that child's neurobehavior. Now, I'm not saying that pesticide exposure is fine for kids, but I'm saying, and it may be we just haven't found this association yet, but in our data, we're really seeing that it's that prenatal exposure is popping out as the important time point.
Do you want to follow up the study you're doing, infant development and environment? Because you have another cohort looking at phthalate exposure.
So the study that we have been working on for the past 5 years looks at phthalate exposure in pregnant women, and then we're looking at reproductive markers in infants, and we specifically look at a marker called anogenital distance. And I guess one of the points that I wanted to make that corresponds to what we've been talking about here is that what we've found in our studies again and again is that the prenatal exposure is what is really important. And for future reproductive health, your gonads develop very early in pregnancy. It's really the first trimester up until about 16, 18, 20 weeks. You have sexual differentiation, and you have testicular development. And the fetal testes are very, very susceptible to chemical exposures. And they can be affected by very low dose exposures. And that is what we've seen in our current study, that although these chemical concentrations have declined and exposures have declined in the recent past, still we see effects on fetal testicular development. And that's the research that we have found most currently to be most important and most relevant to our population. One thing that I did want to say is that for some of these exposures we've been talking about, there are declines in the population. There are declines in exposure concentrations in the population. I think that's partly because of a bigger knowledge base. It's partly because manufacturers know that this research is out there. They either take the chemicals out of their products or they don't use them as much. It's not in the public realm, but we see it in exposure concentrations in the general population. But even with the decreased exposures, we're still seeing health effects. And one of the things that our toxicologic framework isn't good at doing is taking into account multiple exposures, multiple chemicals. So I specifically have been talking about phthalates, but there's a lot of different chemicals that Karen mentioned that can affect the same endpoints. And our risk assessment framework, so the framework that tells us what is the acceptable level for a chemical for us to be exposed to before you would see a health effect, doesn't take into account those multiple chemicals. So if you're exposed to only that one individual chemical, sure, you would need a very, very high dose to get a health effect. But if you're exposed to a low dose of multiple chemicals, you can still see similar adverse health outcomes.
Well, what about some of these other adverse health outcomes? I mean, one of the newer areas of study, and maybe Ted, you might speak a little bit to this, is on obesogens and looking at some of the potential of these endocrine disrupting chemicals and their impact on metabolic system.
Yeah, I'm actually going to talk about that in the last panel today just for a few minutes, but obesogens are chemicals that have been identified primarily in animal studies that actually can increase the likelihood that offspring will be overweight later after birth, both by increasing the number of fat cells as well as, in some cases, increasing the size of individual fat cells. So this gets back to this whole idea of, during the windows of vulnerability, creating set points with exposures that then sort of set the stage for metabolic problems later in life, not only obesity, but also diabetes. There's a growing literature that's showing that early life exposures to some chemicals increase the likelihood of insulin resistance in diabetes. The extent to which this is a real problem in human populations is not yet clear, because we all would agree, I think, that both obesity and diabetes are multifactorial problems. They have a lot to do with much of the system conditions we've built, the way we lead our lives, the diets we eat, the lack of exercise, genetic inheritance, and a whole variety of things. So teasing out the contribution of the environmental chemicals is often very challenging in complex human populations.
Thank you. And Karen, I know you're working like with the National Institute for Environmental Health Sciences and some other federal agencies, and one of the things Karen's been leading is, or organizing is this women's consortium among experts concerned with these issues. And maybe you could talk a little bit about what's happening at that federal level.
Sure. So as a follow-up comment, I'm glad that you did an initial discussion of obesogens, and probably this afternoon you'll cover that there's some new evidence about transgenerational effects of obesogens. So the importance just magnifies as it keeps being studied. And that is some of the work that is happening at the National Institutes of Environmental Health Sciences. There are probably some people in here that would be able to speak even more knowledgeably, but I've been very fortunate to work with many of these researchers. There is a whole consortium dedicated to the study of BPA, so bisphenol A is an additive to plastics that I'm sure most of you in the room know about, and the BPA has been implicated as an obesogen, has many different effects with fertility and pregnancy. In terms of the fertility world, I find one of the most interesting ones is the effect of the BPA exposure on women who are undergoing in vitro fertilization, and in fact the quality of the eggs that they are extracting to go into in vitro fertilization processes, the quality of those eggs declines with increases in BPA exposure. So that's it's very unfortunate. It's also kind of a unique opportunity to study that effect because we don't, for normal healthy women walking around, we don't get a look at the health of our eggs, right? But in vitro fertilization, it's that unique opportunity where those eggs are extracted and they're available for study. So I think that's one very good example out of the consortium.
Well, other comments to each other, I mean, about the transgenerational effects or some of the studies, or, you know, how the different methodologies between some of the studies that have been doing, you know, on the pesticides and these certain community, and then the work you're doing on phthalates. I'm just kind of
I had a follow-up
yeah, sure.
from Sheila.
Good.
Because I had on my notes to mention the anogenital distance studies, because once again, I think it's a really fascinating kind of real-life example that may be of use in the clinical setting. So I wonder if you would elaborate on what AGD is and the fact that it is a physiological marker. I have heard theoretically it might possibly be used as a screening tool. You know, eventually after many years of data have been accumulated, it might be possible to use this physical measure to predict if a male might have infertility issues later down the road. So would you like to comment about that?
Sure. So one of the markers that we look at in our studies is called anogenital distance, and it is a measure between the anus to the genitals, so in males to the base of the penis, or in females the clitoris. And what we've seen in animal studies is that this is a marker of reproductive toxicity. When there's a shortened anogenital distance in males, it's associated with undescended testes, other abnormalities of the male reproductive organs, and it's a risk factor for infertility and testicular cancer, or testicular tumors, I should say, in the future. And so we study this marker in infants because we know it's associated or a risk factor for other potential abnormalities in the future. In terms of it becoming a screening tool, as a clinician, I have my doubts about that, only because I don't think it could ever replace some of the other tools that we use now to potentially predict future reproductive outcomes. But we certainly are seeing in adult males that a shortened anogenital distance is associated with infertility and other reproductive outcomes. So I do think maybe in the adult population it could be a screening tool for potentially poor fertility. But there would have to be many, many more studies done. And I don't think it would take the place of looking at sperm concentration or sperm markers or other measures of fertility that we currently know about. The way in which I think AGD is a really interesting tool for research and for science is that it's really, really hard in these kinds of studies to look at outcomes that can be rare. So if you have something like undescended testes, which happens in 1 in 200 males, to really be able to see, does this chemical cause that outcome, you would have to look at hundreds of thousands of women to look at their exposures during pregnancy and see, do we have undescended testes in their males when they're born? What we can do with anogenital distance is look at it in all newborns and then see, is that anogenital distance associated with future reproductive outcomes? And that's why it's such a great research tool. I do hope that it does become a clinical tool in the future, but I think it'll probably be a little bit better of a tool for adults than for kids.
So Sheila, you said in
Sorry.
Did you say in
human adult males that anogenital distance has been measured and has been found to be associated with infertility?
Yeah, and
Really? Have you guys done that? I haven't run into that.
no, not our group, but the Michael Eisenberg, who he was at UCSF, but I think he's at Baylor now, and he is a urologist, and he has done a lot of work on anogenital distance in adult males, and they've seen that it's a shortened anogenital distance is associated with abnormal sperm morphology as well as infertility.
As you can see, you're getting the inside scoop. Even those who are really immersed in this, there's so much happening right now that it's really hard to stay on top of it. One other area I just want to touch on is just what are some of the trends in research and some of the controversies? Where are we seeing sort of some real pushback and back and forth, not just from industry, but really just among researchers about how we best do this, and thinking of some of the new tools like high throughput, screening and how effective that is, the pros and cons of that. I just wanted to kind of throw that question out there. Any comments along those lines?
When you say what are the controversial issues?
Yeah.
The one that pops to my mind immediately when you said that is I've done some work with BPA. Bisphenol A is that chemical that's it's an estrogen, and it's in plastics and in the linings of cans and in the receipts, some receipts that you get from the store. And that is, I think, a very controversial and very important chemical right now. There's a lot of attention. There's legislation now about whether it should be taken out of baby bottles, baby products, out of all of our products. And I just want to say, from a scientific point of view, it's a really difficult chemical to study, which is unfortunate because it's a really important one to study. But what we're seeing now is some controversies in the animal literature. There are a lot of people that are doing toxicological studies where they're giving this chemical to rats and finding a lot of different health effects, including earlier puberty, changes in breast development or ovarian morphology, changes in learning and development, and obesity is a big one. I'll say that I've done quite a bit of work on the obesity, and when you look at the animal studies, I can find as many studies that don't find obesity as studies that do. So there's some contradictions in the studies. The big controversy right now is that a lot of the people that are doing the rat work say that the levels they're giving to the rats is about the same as people are getting. And there are other people that say, you have no idea. We really can't tell we can't compare a human to a rat, and they're saying that the levels you're giving are way higher than any of us are getting. And most of the people that are on that side of the argument are in industry. But they do have a point. We don't have a good way of knowing exactly what the animals are getting and how that compares to what the humans are getting. It's still kind of an open question. And then the biggest problem for me as an epidemiologist who studies humans is it's very, very difficult for us to know what we're all exposed to in terms of BPA. I can take a urine sample from anybody in the room, and I can tell you how much BPA is in your body, and that reflects how much BPA you've absorbed in the last 24 hours. But tomorrow you may absorb a completely different amount. And so for me to be able to say, what is your sort of chronic, ongoing BPA exposure and correlate that with an outcome, it's hard. We're doing studies, we're finding some associations in humans, and they are corroborating the animal literature, but we all know, those of us that are doing this science, that there are big weaknesses. So, we've published findings of behavior problems in children with prenatal exposure, including, you showed the one by Joe Braun's group that showed anxiety and depression. We also found anxiety and depression in girls and boys in our study. But we know that there are weaknesses to the study. So we want to put out the best science that we can, and we want to be able to put this forth to the policymakers to be able to legislate these important chemicals, but our hands are tied with some of the limitations of the science.
That's really important.
Yeah, I wanted to touch on something that's not exactly a controversy in the scientific literature, but it's more like the bench science literature, it's more the behavior literature. The bottom line is that these chemicals are all around us, we're being exposed, and what do we tell people about avoiding exposure? And what we don't know is when we tell you to avoid, like don't drink out of plastic bottles, don't give your babies, use baby bottles with BPA, we don't know if those behaviors improve outcomes. And you can imagine how hard that would be to study. So it's a big gap, because like I mentioned before, we don't want to end up blaming pregnant women for their health outcomes. We don't want to scare them, don't do this, don't do that, because we don't want to scare them, but also the science really isn't there that says, okay, if you keep all the dust up off your house, in your house, you're going to have fewer flame retardants exposures, and therefore your child's going to be healthier. We really can't say that yet.
Yeah, I just wanted to follow up on Susan's point there about we don't really have good methods or interventions to give to women to reduce exposures. And Susan, Kim, and I both, all three of us, do research on developing interventions to reduce exposures for pregnant women and for children. But yet, I think that the controversy or the issue really comes up in, should we be doing that, or should that really be at a policy level? And how much can we do in terms of an intervention? And I would argue that an intervention that we develop now may not work a year from now, depending on how the market changes, depending on how exposures change. And so I think that it really brings up the issue of, should we be working on interventions to reduce exposures, or should we really be thinking about our national policy on exposure prevention?
Well, Ted, you might be someone good to speak to some of the uncertainty factor in science. And then, as we know, and I really appreciate the candidness of all of you here saying, well, we know this, we want to be able to say this, but we also, there's controversies and gaps and things we don't know yet. And yet we also want to be able to act and prevent, what we can now, even without that certainty.
Yeah, well, I just want to acknowledge. I listened to Kim and Sheila and others talk about their studies. This Chamaco study, they measured a whole lot more than pesticides in the urine. They covered a whole range of things that can affect the neurological development of children. And they have to sort of weave that into the study design. This is hard work. And to see a signal like this that has been reported is really quite extraordinary, because so many other things can influence child's neurological development. The food the child eats or what mother ate, the social environment, and so on. All that has to be taken into account. What I'm getting at is this. At some point, we have to decide how to act based on what we know. And many careers could be spent further studying just these chemicals that have been described here, and there are lots more. And as has been noted, we're exposed to a whole mixture of chemicals. There's a whole mix of social environments, nutritional environments, and so on that people are conceived in, that develop in, and grow up in, that can have strong influences. So at some point, we have to decide as a society when we know enough to act. And my view is that when evidence is sufficient, and that's as much a political question as is a scientific question, that we should decide to take actions. And Sheila has made an argument for taking policy action, and I agree with that. We're not going to accomplish nearly as much as if we're in the clinical setting advising individual couples to take certain kinds of action as we can do if we look at it from a public health perspective. We should not be feeling complacent with virtually everybody in this room and in our society having measurable levels of bisphenol A in their urine. Virtually everybody, given what we know from the animal literature, even though it's inconsistent, as Kim has described. This is not a picture that we should be supporting. We should be doing what we can, I think, on bisphenol A and others where exposures are so universal, to reduce those exposures based on the evidence that we have now. It's always going to be imperfect. There are always going to be uncertainties. But, first do no harm is sort of a leading idea that we have in medicine, and I think we should be applying it at the public level as well.
Thank you, Ted. Oh, Karen, do you want to make one more?
Yeah, I just want to follow up on what you said, because it's so very, the points you make are so very important. I think everybody in the room would agree that policy changes are needed. And I had heard a very interesting analogy when talking about federal chemical policy as it stands now and people who would like to reform it. So there's this concept that if you were looking at a case in a civil court and you were trying to determine if the person was liable or guilty or what have you. In the civil court, we are just requiring, our court system just requires a preponderance of evidence, right? And if you're looking in a criminal court, our court system just requires the beyond a shadow of doubt. The person is likely to be guilty, beyond a reasonable doubt. But that our current chemical laws at the national level require that the chemical produces a certain effect beyond any shadow of a doubt. So that different level of burden of proof is really something that I think is due to be changed. So.
That's another important piece of this. And I also note the time, and Margot is signaling me over here. So I know we feel like we just began, but we have this next segment.
Thank you so much to all of you. We are going to keep you up there for a few minutes. Feel free to take a little water break as we do some work at our table. I just fascinated by everything that you have to say. Certainly there's much more to learn today. You can tell that this morning's panel, we're really hitting you hard with some of the science and the background to establish a strong foundation as we move forward in the afternoon to talk about, well, what the heck are we going to do about it anyway? And so just know that we're moving sort of from science into more of the action conversations later in the day. I wanted to give you a moment to sort of reflect at your table. Remember, I gave you the handouts with the notes. What did you hear that is new to you? Certainly, I heard about 20 things that's new to me, and I've been working in this field for a long time. What did you hear that was new to you or that really resonated with you personally? I wanted to give you about a minute to think about that, jot down some thoughts at your table, and then please, we actually intentionally mixed you up at these fantastic tables so that you could get to know new people, not just in your field, not people who you may run into every day, not your colleagues, but people who are working across in different sectors in different fields, because we know that to address these types of issues that have all sorts of different causes and linkages and connections, we have to work together. So take a minute to do some thinking, jot down some notes, meet your table mates, introduce yourself. You got 5 minutes to work at your table. We know that in those 5 minutes, you guys are the experts. Probably a lot of the questions that came up for these panelists, you can actually answer at your table. So talk amongst yourselves. What resonated with you? What question did you leave that panel with unanswered that you would like to hear more about? And then we'll turn it out open to question and answer for a few minutes. I want to get some good questions from tables peppered up to this amazing panel. So raise your hand, hop up, get energized. If you have either a question or maybe a comment that you just wanted to say that you jotted down at your table. Note to self, I should have worn my sneakers today or something. I'm going to get my exercise. Yes, go ahead, stand. You got to stand up, though, and say who you are and who you work for and own it. Okay.
Scary. Hello, I'm Amelia. I work for the YWCA and in Public Health Infant Mortality Prevention Network. And the question that kept recurring in my mind as you all were chatting was about the impact, or not the impact, but the study of epigenetics and the intergenerational impact of racism. And I'm curious if you all could speak to that or if there's anyone who's doing research on that. I feel like our table would be pretty interested. Thanks.
Excellent question. So because you were so brave, you actually get a choice between a sippy water bottle, I believe these are meant for children, or a Theo organic fair trade dark chocolate. It's orange too. She's taking the sippy.
Yeah, I don't deserve that.
That's a wise choice.
Yeah, I'm not personally.
Maybe. Okay, so we are going to have, of course, the panel next talk about more of the cumulative impacts. But if anyone wants to take a stab at that right now, we can jump into it.
Well, I will say that the issue of racism is really important for a variety of reasons, obviously, and in health it's very important. And some people study stress and put racism into that category of stress. Stress is a big literature. And there are reasons for doing that. But so there are studies showing that there are epigenetic markers that are laid down by stress. In animal studies, you can't do racism studies, but you can do stress studies. And you can look at the effects on stress hormones and other markers of stress, biologic markers of stress in animal studies. And you can measure those same phenomena in people. So it's reasonable to assume that some of that animal information is translatable into human biology. But putting racism together with epigenetic markers in humans, I don't know that that's been done. But stress in animal literature has been done.
Yeah, I just wanted to say that in our study, our kids are about 2 or 3 years old, and we are going to continue the study in the future. And that is one of the biggest things we're looking at is stress, as opposed to specifically racism. I think in these kinds of scientific studies, it is really difficult to study racism. I mean, that's almost a social science topic in and of itself. But I do think it's being taken very seriously. And a good example of that is I sit on the Children's Health Protection Advisory Committee for EPA. And one of the letters we just wrote to the EPA was all about social determinants of health and how the social determinants of health really need to be incorporated when you're thinking about environmental threats and impact on health outcomes. But I haven't seen studies that specifically have focused on racism, but the stress and the way in which we measure it, I do think does take into account some of the factors that you have touched on.
You want to have some more time for questions? Let's see, Nicole, did you? She's eyeing this chocolate here and saying, I have a question. Oh, she doesn't want the chocolate. It's for me then. Stand up, say who you are.
Nicole Thompson, Public Health Seattle and King County. And I've been focusing on healthy housing lately. But my question is more about the replacement chemical factor, right? Because we talk about chemicals and all your research is mostly on not classes of chemicals, but a specific chemical response. And I'm concerned with the substitutes that are brought up. So we phase them out and a new one comes in. So at what point do we start talking about classes of chemicals or broader buckets to put them in to respond either on a policy basis or on an individual intervention method?
Great, thanks, Nicole.
I think we start talking about it now. I think we start talking about it, in the past. I think you're raising a really important point. I think there's a little bit of as scientists, we're kind of chasing our tails. Like I said, I've done a lot of work on BPA, and there's all this work on BPA. Well, BPA is coming out of products left and right, but I don't know how many people realize what's going in instead. So a lot of things that say BPA-free now have BPS, or BPAF, or BPD. Because if you're a chemist and you've been told that this chemical's been taken out of your toolbox, naturally you're going to look for a related chemical that has the same properties. And so you're going to stick this related chemical in instead. So, I mean, one of the messages that I tell people is, I see a lot of BPA-free water bottles. I don't know what's in them. I tell people, I buy this, I buy metal. I don't buy BPA-free because I don't know what BPA-free is. And I don't know what the BPA replacement chemicals are doing. And as scientists, we're playing catch-up. It's going to be a few more years before we know what these chemicals are doing. So I think you're absolutely right. We need to be looking at the bigger class. And the problem is, I think it has to do with our chemical policy. I think it's partly that industry is forcing us to be so microscopic and look at one chemical at a time. And we don't want to do that. We want to step back and look at classes of chemicals, or even look at an entire overhaul of the way we regulate chemicals, to be thinking of them not as innocent until proven guilty.
And just to follow up on that, there's also the whole relatively new field of green chemistry. So going back to the fundamental building blocks of what makes a particular chemical, and can we start with these principles of, is it benign all the way through its life cycle? And so when, I'm a chemist in that lab trying to figure out what chemical I'm going to develop to have this particular effect in a product, can we think about it in a very, very different way than traditional toxicologists were thought to think about synthetic chemicals and making chemicals. So that's a whole nother field that is emerging, and a really, really important one when we're thinking about substitutes and alternatives.
Excellent point. Okay, we have time for one more quick question, then I have a few things to mention before we go off to our break, but one more quick question, yes.
I'm Jordan Keith with Urban Wilderness Project. I have a quick statement answer about your classifying chemicals, the cumulative health assessment that the EPA is doing. There was a talk You can Google it, on water, and they were talking about looking at effluents that have the similar health outcomes being clumped together as a way that, since you can't pinpoint one criminal, you can say this group together can't be allowed. My question is about epigenetics and uterine fibroids. I wonder if anybody's looking at that, because people of African and Latino descent have such a high rate. And I wonder, have people looked at, obviously, the stress of slavery, but also what other current effects might make the rate so high for these tumors?
Thank you. Jordan, can I give you this chocolate? You just demonstrated for me making an offer. It was sort of an offer. What she said was, I offer you, Nicole, this information of what I know about what EPA is doing on cumulative exposures. And we're going to talk about making requests and offers later in the day to each other to really bring in the power of this network. So you get a Theo chocolate bar for your beautiful offer. And to the question. Which one? Fibroids. Anyone?
I mean, there's a lot of work being done on endometriosis and some of the fibroids and chemical exposures. I don't know, I'm not the research scientist here, so I'm going to kind of turn back and say there is that piece happening. I don't know if it has the other component.
Well, I worked with one of our PhD students did research on organochlorine, pesticides, and phthalates in relation to endometriosis, and found relationships between the organochlorine pesticides, which are very persistent. They're persistent in the body over time, and that's why we could look at them in the way that we did. We looked at the concentrations after the women were diagnosed with endometriosis, and she found significant associations with those. With the phthalates, the associations were not quite as strong. In terms of fibroids, I'm just not aware of any research looking specifically at fibroids and specifically at the vulnerable populations who have the highest incidence of those. But I will think more about that. I don't know if anyone else.
Thank you.
Thank you so much for
Great
those
question.
very thoughtful questions, very thoughtful questions. And because I am standing between you and a break.